Hello, good afternoon, everyone. Today is 22nd of April 2017, and right now I'm going to talk about how to evaluate a patient with joint swelling, or in other words, you can say how to evaluate a patient who is having a rheumatic disease. So, first of all, you have to answer 3-4 basic questions before going further and before you decide what the reasonable diagnosis is and what the reasonable plan of workup is. So, the first question which you have to answer is about the distribution of the joints in various disorders, and the most important part of the rheumatic disease evaluation is to basically understand the type of the involvement of the joints, and the most important type of the distribution which we see very commonly in the clinical practice is a polyarticular symmetrical type of pattern where more than 3 joints, usually 4, 5, 6 joints are involved, and we are having 3 typical diseases which presents in a polyarticular symmetrical fashion. Symmetrical means that if my right PIPs are involved, so is my left PIPs, or if my right wrist is involved, so is my left wrist. So this is called as symmetry, and we are having the 3 typical diseases over here. The first is rheumatoid arthritis, which typically involves the small joints. The second most important disease is systemic lupus erythematosus, which almost presents in a similar way like rheumatoid arthritis as far as the type of arthritis is concerned clinically, though SLE is a little less inflammatory disease as compared to rheumatoid arthritis, because of which you will not see erosions that commonly as in case of rheumatoid arthritis. But in lupus, if you will see a patient clinically, it's not possible to distinguish whether the patient is having lupus or whether the patient is having rheumatoid arthritis just on the basis of the arthritis, because SLE is usually a multi-system disease. So these patients are usually having rashes, they're having involvement of the kidneys in the form of lupus nephritis. These patients are usually having hemolytic anemias. These patients may have seizures, personality changes. So on the basis of this multi-system stuff which you see commonly with lupus, you can distinguish it from rheumatoid arthritis. Then we are having the various viruses which can cause a polyarticular symmetrical type of arthritis, and the cardinal viruses are Epstein-Barr virus, EBV. Then we are having the hepatitis B as well as hepatitis C, and then we are having something called as a parvovirus B19 infection. We all know that parvovirus B19 infection is classically seen usually in adult population in females or men, but usually females who are working in a kindergarten, and this infection they'll get from little kids, and this is also called as the 5th disease or erythema infectiosum. And in adults, usually they are having a polyarticular symmetrical type of arthritis, and they're not having that typical slap cheek appearance and the various skin manifestations which you typically see in pediatric population. Then we are having the monoarticular type of arthritis, which typically involves just a single joint, and we are having 3 important differential diagnoses for monoarticular type of arthritis, and these are: the first one is osteoarthritis, then we are having the septic arthritis, and then we are having the gout and the pseudo gout. The chief difference between gout, septic arthritis on one side and osteoarthritis on the other side is this: that osteoarthritis is usually chronic, so we are having history of weeks, months, or sometimes years, whereas usually the arthritis is very short. There's a very short history of arthritis in pseudo gout, or in patients of septic arthritis, usually a few days. Then we are having the migratory type of arthritis. So after polyarticular symmetrical, then we had monoarticular, and now we are having the migratory type of arthritis. So typically we are having again three diseases. The first one is the Lyme's disease. We don't see in India. It's endemic in United States of America, especially in the East Coast, and it's usually caused by a bug. The bug is Borrelia burgdorferi, which is usually carried by Ixodes tick. And Lyme's disease usually causes a migratory arthritis, where the disease jumps from one joint to the another. And then we are having GC, or the gonococcal arthritis. It can present in two fashions basically. It can present either in the form of a monoarticular type of arthritis, or it can also present in the form of migratory arthritis. And then we're having the rheumatic fever, especially in country like India, where still we see patients of rheumatic fever later on progressing to even RHT. Then lastly, we're having the patients who are having oligoarticular arthritis. And in oligoarticular arthritis, usually less than 3 joints are involved, and it's oligoarticular asymmetrical actually. So there's no symmetry, and there are two basic conditions where there is oligoarticular asymmetrical type of arthritis, and the most important among these two is seronegative spondyloarthropathies, which usually comprises of either enteropathic arthritis. They're having enteropathic arthritis, which includes both UC as well as Crohn's. They may have the Ritus syndrome, or what we call these days in a better way as reactive arthritis. These patients may have ankylosing spondylitis, being the hallmark of all these seronegative spondyloarthropathies, or they may have psoriatic arthropathy. These are the 4 typical disorders which are listed under the umbrella heading of seronegative spondyloarthropathies. And then sometimes osteoarthritis can also present in a similar way, like involvement of the knee, then involvement of the wrist and the 3 fingers in the left hand. Typically it involves the PIPs in contrast to other diseases. Usually PIPs are involved typically in case of osteoarthritis. So this is the way how basically you'll distinguish that which type of arthritis is there. Then you have to answer whether it's an acute disorder or whether it's a chronic disorder, and that will be distinguished on the basis of the history. Then you also have to ask about the presence of various systemic symptoms or signs which you can see in a patient. For example, in a patient who is having Sjogren's syndrome, or in a patient who is having systemic sclerosis, or in a patient who is having vaginous granulomatosis, sometimes they will present in a similar way with polyarticular symmetrical type of arthritis. But now somebody will ask me that why I have not listed these 2-3 conditions along with my differential diagnosis of polyarticular symmetrical, where I just talked about rheumatoid arthritis, lupus and viral arthropathies. The reason was this, that in these particular disorders the patients are usually having tons of other symptoms. Like in Sjogren's, they are so dry, they're having keratoconjunctivitis sicca, they're having no saliva, so they are all messed up with these symptoms, that arthritis is usually not the chief complaint. And similarly, in patients who are having systemic sclerosis, all their symptoms are usually confined to Raynaud's phenomena and thickening of the skin. Or in vaginers, where they're having recurrent sinusitis and rhinitis, or they may develop glomerulonephritis sometimes very early in the course of the disease, because of which these patients usually will not give that much importance to polyarticular symmetrical type of arthritis, which basically stands out among all the symptoms in case of rheumatoid arthritis, which is usually having paucity of the systemic features, where the extra-articular manifestations are usually not very common. And in lupus, where usually you'll see the complications a little bit later, and initially you will see the typical polyarticular symmetrical type of arthritis. Then the next thing is sometimes to distinguish on history and on physical examination that whether the patient is having arthritis or arthralgia. One important point to distinguish is this, that in patients who are having the joint pains, first of all you have to ask them about the history of the stiffness. So stiffness is equivalent to inflammation. So joint pain, when the patient is having joint pain and you really want to rule out inflammation, you have to take the history of the stiffness of the joint. The patients may have the erythema of the joints, joint may be a little warm, and then there are certain lab parameters like you can go for CRP, you can go for peripheral WBC count, or sometimes you can do arthrocentesis in patients who are having acute arthritis, usually the monoarticular arthritis, and usually in the setting when you are a little confused whether the patient is having septic arthritis or gouty arthritis. In the clinical practice, it's advisable to always go for arthrocentesis whenever a single joint is involved, and there are just two exceptions or two contraindications for going for arthrocentesis, and the one is if the patient is having a bleeding diathesis, or sometimes if the patient is having overlying cellulitis, because you don't want to take the infection inside the joint. So apart from this, in all the patients you have to go for arthrocentesis if the arthritis is in a monoarticular fashion, and most of the times in septic arthritis the counts will be very high. They are usually more than 50,000, sometimes approaching a lakh, or sometimes a little bit more also. And also, if you really want to rule out gout or pseudo gout, you can make it out by going for an arthrocentesis where you see negatively birefringent crystals, which are usually needle-shaped crystals, and the appearance is as if there is olive in a martini glass, which you see typically in gout, in contrast to pseudo gout, where you see usually a positively birefringent crystals. They are usually rhomboid, sometimes hexagonal or octagonal, so that's a different story. So apart from this, the examination of the patient is important, and if you are suspecting rheumatoid arthritis clinically, but then the patient is giving you history of a lot of systemic features, and the family will tell you that patient is not keeping with herself lately, because most of the times the lupus is more common in women. The ratio is likely 9:1 in contrast to 3:1 which you see in rheumatoid arthritis, and these patients are usually having a little bit of something which is like encephalopathy, which goes on for long, and personality changes, which are then followed by the arthritis, and then the rashes, the typical photosensitivity, malar rash or discoid rash you see. So that's the reason that why they always say that whenever you are evaluating a patient of rheumatoid arthritis who are typically presenting with a polyarticular type of a monoarthritis, you should always look for lupus. And if the patient is having a lot of systemic manifestations, you should go for specific serum antibodies to see whether you are not diagnosing the patient wrongly with rheumatoid arthritis, whereas actually the patient had lupus. So this is the way how we go. First of all, you should be knowing about the distribution of the joints. Then you should be knowing whether the disease is acute or chronic, especially in the monoarticular type of arthritis. Then you have to see the symptoms beyond the arthritis. And lastly, you should be knowing about inflammation and what are the indications of going for an arthrocentesis, and how you actually see the results of arthrocentesis. And there's a typical thing which you do 3 C's. You see the cell count, you see the crystals, and then you send it for culture, especially to rule out septic arthritis, where the bug usually is going to be Staph aureus in sexually non-active patients, usually the adults, whereas the bug is usually going to be gonococcus in Neisseria gonorrhea in the patients who are usually sexually active, because the therapy is going to be different. So that's why you can also go for culture of the fluid from the joint space. There's no need to go for protein, sugar, LDH and all that stuff. So cell count, culture, crystals ends the story. It wraps up the arthrocentesis story. So I guess this is enough for today. Next time we will be talking about further disorders in rheumatology. Thank you.